Hi, this is Dr. Coucher. I'm going to be talking over Chapter 57. We're going to discuss pharmacology with drugs for men's health, reproduction, male patients with chronic, acute, critical, and mental health care needs. Alright, so androgens or male sex hormones, they control the development and maintenance of sexual processes, accessory sexual organs, cellular metabolism, and bone and muscle growth. Testosterone is our primary androgen. It's also an anabolic steroid. The administration, it's usually done IM and it is very well absorbed, done with an IM injection. It is excreted in their urine and bile, and the onset and peak are actually unknown at this time. However, if you do have a man that goes to a clinic for a testosterone injection, likely they're going to receive a B12 at the same time to kind of help with the uptake of it. Indications for it are going to be hypogonadism or delayed puberty in adolescence. With male hypogonadism, it's a defect of the reproductive system, and it does result in a failure of the testes to produce the testosterone sperm, or actually it may not produce both of them. So androgens include androderm or testoderm TTS. It's a transdermal patch, usually in about 5 milligrams. It's changed every 24 hours. It's not applied to genital, skin, or bony areas. Androgel is also another form of it, and it's only one type of androgen replacement drug. There are several others, though. You have Fortesta, Axiron, Striant. If in use, it is important to teach the man to ensure he receives regular evaluations of his serum lipid levels. Striant is a buccal adhesive testosterone system, and it's used to treat androgen deficiency. It is very well absorbed that way. Just think about the mucosal lining. Important teaching concerning its use: that it must be replaced if it has slid out of position for more than 4 hours. Other uses include treatment of refractory anemia in men and women, hereditary angioedema, tissue wasting associated with severe or chronic illness, advanced carcinoma of the breast in women, and endometriosis. We're going to move on. I'm going to talk to you. I know I just did some testosterone, and I gave you some other androgens that you might see. With testosterone, we're going to look at some drug interactions, and you're going to see this a lot of times with these androgen drugs. It does increase the effects of anticoagulants, decreases the effects of barbiturates, phenytoin, antagonizes calcitonin and parathyroid. And the corticosteroids will exacerbate any edema. Lab interactions, it does decrease blood glucose in diabetics, but it does increase the serum cholesterol, thyroid, and liver function, as well as the hematocrit. The side effects, priapism, gynecomastia, spermatogenesis might be halted, oligospermia. Some adverse reactions that we might look for would be hypercalcemia, virilization, teratogenic effects, and hepatic carcinoma. We want to definitely caution these men that we prescribe any androgen to. They are going to be at risk for some hypertension. We're going to watch their cholesterol, cardiovascular disease, renal disease, seizure disorders. And I'm not going to talk too much about infants and pubertal children in this one, but these are just some we will cautiously look at giving that to them. There are some different things that your book cautions about, but we're focusing definitely on the men right now. So why would an androgen be contraindicated? Well, if we're having to give it to a woman for any reason, pregnancy, nephrosis, or the nephrotic phase of nephritis, hypercalcemia, pituitary insufficiency, hepatic dysfunction, BPH, prostate cancer, a history of myocardial infarction, or men with breast cancer. Anabolic steroids, these are also called anabolic androgenic steroids, AAS. This is a class of steroid hormones related to the hormone testosterone. They increase protein synthesis within cells, which results in the buildup of cellular tissue anabolism. especially in the muscles. This class of drug will beef up the masculine characteristics such as the growth, and we're talking like growth of muscles and vocal cords and body hair. And we'll look at some of those on the next slide. But there are two new and upcoming ones that I just wanted to mention that are being abused. The human chorionic gonadotropin, HCG, progenyl, novaril, ovidrel, and the THG, I want to try to pronounce that, tetrahydrogestrone. Uh, Sorry, I butchered that word. That this is potent and it's not actually been approved for in the U.S., but these are some drugs that athletes who are going to abuse are actually getting a hold of and abusing these drugs. So those testosterone precursors, the anabolic steroids that I was just talking about, they're popular with the athletes. They can be obtained in nutritional substances. They're selling them all the time. What is that one commercial? I can't even think of it right now. But they're always sending us a little reminder on TV that you can purchase this because this athlete has it, and he's actually improved his stamina in the gym and stamina in the bedroom. So yeah, it's going to appeal to people that are athletes and wanting to kind of beef up their muscles. And here we have a few of them that you can find within some of these substances. The health risk from the long-term use, they could have an increased LDL, decreased HDL, increase in acne, high blood pressure, liver damage, and dangerous changes in the structure of the left ventricle of the heart. So we definitely want to caution about these nutritional substances that we might see our young people getting a hold of, and even some of our young men in their 20s. So let's look at our nursing process. We want to make sure that we're assessing when we're giving starting patients on androgens, whether it's the testosterone or any of the other substances that I talked about. What about the patient's perception? How are they viewing themselves? How are they actually viewing the fact that they might have to have a testosterone replacement? Weight, blood pressure, liver and thyroid function. We want to look at their H&H and creatinine, clotting factors, their glucose tolerance. We might want to run an A1C on them. Serum lipids and electrolytes. Furthermore, we need to assess the patient's expressive efforts. After we started them on injections or any of these other meds, are they more aggressive? What's their self-concept like? You have to think, and I guess as a woman that it might be a little bit difficult for me to comprehend and grasp a hold of, but as nurses we need to be very cognizant of the fact that women are going to view things completely different than men do. And we're going to review testosterone replacement as probably something that's no big deal. I view hormone replacement for myself as no big deal, but for men, everything is so wrapped up into their sexual response and their ability to be all the man that they want to be, that we really have to look at that with them and how they're perceiving themselves. When we're diagnosing, we might need to look at disturbed body image, delayed growth and development, situational low self-esteem, sexual dysfunction, ineffective sexuality pattern, or readiness for enhanced knowledge. With planning, we need to collaborate. It has to be a collaborative effort, starting with the patient. If we're going to start them on a therapy, we need to know that they're actually going to follow through with it, correct? We need them to make sure that they report any adverse effects immediately because it's imperative. The goal would be to achieve and maintain a self-concept during the long-term treatment. Patient teaching, this is very important. Very, very important. A man undergoing androgen therapy may not be able to assist in conception if he or his wife decide to begin trying. It's important for them to know that it may take up to 3 months before conception will occur. And this is something we really need to talk about on the front end for these patients. All right, so anti-androgens. They block the synthesis or action of androgens. Excuse me. Uses is treatment of benign prostatic hypertrophy, advanced prostatic cancer, and as a hormonal treatment in the treatment of endometriosis. Other uses would be treatment of male pattern baldness, acne, hirsutism, virilization syndrome in women, and precocious puberty in boys. Anti-androgens are leuprolide is a gonadotropin-releasing hormone that is most effective inhibitor of testosterone synthesis. Ketoconazole is an antifungal drug that has testosterone-suppressing effects similar to those of GnRH. Flutamide or Ulixin, it is an oral non-steroid anti-androgen drug used to treat metastatic prostate cancer. Aldactone, and this is our weak potassium-sparing diuretic, can be used to treat acne, POS, and also females with hirsutism. Drugs used in other male reproductive disorders. Um, some of those developmental disorders can be undescended testes. So this would be associated with infertility or testicular cancer. We also might have some delayed puberty. So we might not have secretions of GnRH, LH, or FSH. If it's insufficient and and it can be actually insufficient in up to 5% of cases of delayed puberty. That may be what it is. So we're gonna have to replace this. So they're gonna go on this therapy in order to to bring on puberty. We have some pituitary, thyroid, and adrenal disorders where you're going to have some inadequate pituitary function, and it could also cause some hypogonadism. We're going to look at meds such as minotropins. These are purified combination preparations of the human pituitary gonadotropins, and also FSH and LH. It encourages spermatogenesis in males with the primary or secondary hypogonadism. Um, so a patient with inefficient thyroid and adrenal gland function, they might also experience some problems with sexuality. And I'm just touching on them. I'm really going to get to the drugs, but you just need to know when you're taking care of patients with hypothyroidism or Addison's disease may have some problems with sexuality. They might not be able to perform up to their maybe their previous function. Um, this is something I always think about when I'm assessing patients and I'm taking a history on patients. And this is something that we should all think about is asking them these questions. And I know it's difficult when we think about sex and we think about sexuality and male function and female function. But this, especially for men, just think about, and I know I'm saying it again, all their sexuality is wrapped up in how they perform and how they look. So I think that this is something good that we should assess in them and make sure that they are doing okay, because they might not reach out to us for any type of help. Sexual dysfunction, and this is where I was leading into with those other two, such as hypothyroidism and Addison's. Excuse me. Um, it's the inability to experience sexual desire, erection, ejaculation, and/or the phases of sexual response cycle. They could have ejaculatory dysfunction or erectile dysfunction. Um, and you know, a lot of men don't like to actually reach out, and they kind of suffer in silence, and so consequently their partner suffers in silence also. This is why we should make it a good rule of thumb when we're doing these assessments to check the medications that the patients are on and find out and just ask the question if they're having any problems in this area. Viagra, I think this is one we've all seen often. For years on TV, we would see the commercial. They were going to Las Vegas, and you would hear the Viva Viagra song come on because they were an older couple that had been experiencing problems, and now he's on Viagra. So, This works best on an empty stomach. The onset is 30 to 60 minutes with a 4-hour duration. Side effects are abdominal pain, diarrhea, and heartburn. Levitra is less effective with a high-fat meal, so we want to make sure we teach them not to eat something highly high-fat. Don't go out and eat a huge cheeseburger before you take this med. The onset is 25 to 30 minutes with a duration of 4 to 5 hours. It can be used once in a 24-hour period. Cialis is probably one of the most preferred because it's not affected by food. The onset is 15 to 60 minutes, but here's the thing, it can last for 24 to 36 hours. Side effects do include abnormal vision or sensitivity to light. We're going to talk about some of the drug interactions on the next slide. We have to talk about drug interactions, but I have to see if I can get this YouTube video to come up in here. I'm not sure if y'all could see that video or not, when I did that. If not, I would like for y'all to go on and look at that. It is pretty funny. If you've not seen the movie Something's Gotta Give, then you wouldn't, or if you have seen it, then you know what I'm talking about. But one of the big things with these medications is that we don't want to give them any kind of nitrate. Especially nitroglycerin, none of those that need to be given with any of those medications. Alpha blockers, anti-infective agents, cardiac medications, HIV protease inhibitors, and then there's some other medications like methadone, pomazide, and Haldol. I mean, I really did not know about Haldol until I started doing this lecture a few years ago. But they have not been substantiated. You need to be aware of all these medications that many may choose these alternative versus seeking treatment when they begin taking absolute sheer embarrassment, or they might just decide that erectile dysfunction is the way to go. Some other things to think about is probably one of the doing patient teaching with them. There's one that's not listed on here, but I know that, so we want to do some teaching with them. We want to talk to them that are out there for women and men taking any of these medications. A lot of natural products. And one is called, if they're older than 65, we may want to decrease their dosages of it. Horny goat weed is what it's called. The liver and renal impairment. If you see some of these on a patient's list, they need to be very aware of it and check with other medications that they might be taking, so that they're not having reflux, possible adverse reactions. It has to be used in patients. Drugs for treatment of BPH. First of all, this is benign prostate hyperplasia. It does occur with a large portion of older men. They may exhibit signs and symptoms of bladder fullness, frequency. They might go to the bathroom a lot at night, or they might start having hesitation at the initiation of urinating. The 5-alpha reductase inhibitors, finasteride or Proscar, and D-oltesteride, taken indefinitely, will cause a decreased libido for the man and some erectile dysfunction. Women of childbearing age need to be careful about handling any crushed or broken tablets due to possible absorption and the potential risk to a male fetus if they're carrying one. Some other drugs for it, these are alpha adrenergic blocking agents such as Flomax. Flomax can be used to promote kidney stone excretion in both male and female. It can cause some postural hypotension, dizziness, and fatigue. Cardura, Hitrin, Uroxtrel. You want to take these medications with food. You want to teach your patient about the signs and symptoms of postural hypotension, caution about driving, operating machinery, or performing hazardous tasks. Inform the patient that orgasm with reduced or no semen does not pose any safety concern and is reversible once they are able to stop this drug. Advise the patient to notify an ophthalmologist about the use before they have any cataract surgery or any other eye procedures. That is the end of this very quick lecture. I hope that it helps y'all with the upcoming exams.